Perfect.
All right. Sorry for the hiccup. So I'm Brian Jankowitz. I'm at JFK University Medical Center in Edison, New Jersey. I keep trying to creep closer and closer to Chris, and I'll get to New York one day. Um, I'm a neurosurgeon by training, but I fell in love with treating blood vessels a long time ago, and ICH in particular. My task was to talk about initiating an ICH program from scratch. You might ask why. Well, in the last 6 years, I've had quite a bit of experience hopping from center to center. Um, and I really want to make sure that you appreciate that this is a no frills uh, talk that really gets at the heart of what you need to do to start an ICH program. So this is what I would give to my fellow who's a PGY 7 or PGY 8 and about to start a job for the first time. Because there's so much information coming at you that it can be overwhelming, but you really have to cut through it to the few things that are really going to help you start a program. And the beauty is too that much of this can be used to start an oncology program, a DBS program, a functional program, a spine program. I certainly hope there are some young investigators out there because this may fall a bit flat on some of the more senior people out there. But I would encourage you to speak up during the talk or at the end of it and wildly agree or disagree with me because I'm going to be as subversive and as aggressive in my opinions as possible, just because I've been through it many times. And so once again, my journey was at the university, it started at the University of Pittsburgh until 2019 when I left for Cooper Medical Center in Camden to run their cerebrovascular program. And then I jumped ship to the University of Pennsylvania in 2021 to do the same thing, and then jumped to JFK University Medical Center in Edison, New Jersey, to be the chief of neurosurgery. And in every one of those spots, I consider myself the primary ICH evacuation guru. I may or may not have been, but my goal was to initiate a program at every one of these sites. And I learned a lot because there is no cookie cutter method, and you have to bend with the wind in many ways. And I've learned to do that begrudgingly. And so maybe you can learn from my mistakes when you start your own programs, because what works for Mount Sinai will not work at many places. I've I've been entrenched in this for so long that sometimes it's easy to lose sight of, what is going on outside of centers where you really have a zealot that is focused on ICH evacuation. And this is actually one of my favorite ways to utilize ChatGPT. So I asked ChatGPT, you tell me, how do you initiate an ICH program from scratch? And so what I'll do is I'll be toggling back and forth. This is what ChatGPT, which is effectively an amalgamation of what you're going to read in the lay literature, and then I'll simplify it. I'll streamline it to what I think is the most important part or component of that slide. So the mission of an ICH program, yes, it should be rapid ICH identification and safe and timely ICH evacuation with a standardized management protocol, all with the goal of improving neurological outcomes. But I will tell you, it all starts with knowing about every ICH that walks through your door. If you can't do that, you cannot initiate an ICH evacuation program. And there are many ways to skin this cat. By far the easiest is an app that sifts through imaging, but it can be done in many different ways. When I was in Pittsburgh, I had the world's best research coordinator who would comb through the admissions the night before, and then we would go over every ICH admission by ICD-9 codes the next morning, sifting through and deciding if any were a possible candidate for surgery. When I went to Cooper, we were lucky enough to have an early beta version of Viz to diagnose ICH and even give you volumetric analysis. I mean, what an absolute game changer that was. Completely replaced my research coordinator. And I will mention that is that what made at least Viz so important at that time was you have to funnel every non-contrast head CT through your app. If you're just using Visirapid to evaluate your stroke insertion CT, CTA, CTPs, you're going to catch 90% ischemic stroke and only 10% hemorrhagic stroke. So you have to, before, like as your system is getting set up to have an app, you need to make sure that every single non-contrast head CT is run through the app to sift through all the ICHs that you will inevitably miss. This was absolutely essential. And I have to say, Rapid was always behind the times in promoting that ideology. they were so focused on just stroke detection, by that being ischemic stroke, that they often had a wonderful product, but it did me no good because we weren't sending the non-con CTs through it. When I left Cooper to go to Penn, we had Rapid, and I was really dismayed. I knew they could be every bit as successful as Rapid, but they didn't have a specific ICH evacuation module. They still don't have a volumetric analysis. They still don't highlight the volume of ICH, and they still aren't as helpful with getting every non-con CT scan run through the app. And then so when I went to JFK, where we had Rapid as well, I just dispensed with it. I don't use it. And I rely on my stroke fellows to call me for every single ICH that walks through our door. Every time an ICH comes through, from 1 milliliter to 150 milliliters, I get a text with an image, and so I'm aware of what's going on. Chat would tell you that you need to build a core team of neurosurgeons and critical care docs and stroke neurologists, on and on and on, to have a successful ICH evacuation program. And I would tell you that all you need to do is target whoever controls that patient, and it's often quite different depending on what institution you're at. In Pittsburgh, we were very lucky. We had a very well fleshed out cerebrovascular call schedule. And if an ICH came in, the first person called was neurosurgery, and we saw or oversaw the care of that patient until we deemed it non-operative, and then we would hand it off to neurology. When I went to Cooper, it was neurology that was in control of all ICH patients, but they were very open-minded, very forward-thinking, and so it was an easy and natural collaboration to get the neurologists on board to be open-minded about operating on any ICH that walked through the door at Cooper. At Penn, a much bigger system, just too many cats to herd. That was one issue that I faced. And then two, it was neurocritical care. This was very different for me. Neurocritical care was the primary accepting attending for all ICH patients, which means it was the critical care docs that you had to go to talk about the potential for surgery. And they had an enormous team, so it was very difficult to track down 24 different neurocritical care attendings who came from anesthesia, general medicine, surgery, neurology, unfortunately not neurosurgery. And so I struggled to kind of wrest control of the management of ICH at Penn in particular. And then finally at JFK, neurology was once again in charge of all all ICH patients, even when they went to the ICU. And because they're also, I think, a much smaller group of neurologists, much easier to convince and befriend six neurologists or 4 stroke neurologists as opposed to 24 critical care docs. And so I feel like I'm back in a more intimate conversation about ICH evacuation than ever before. But once again, you have to tailor your outreach to the specific group that is controlling the workflow of that patient. If you ask ChatGPT, well, then once you've identified the patient, who's a candidate for surgery? And I was impressed. GCS greater than 5, size greater than 20 ml. Chris, clearly Chat did not look at Misty or Enrich and looked right to the mirror registry for a slightly lower baseline hematoma volume. Ideally within 24 hours, obviously looking at your literature. But I would say dispense with all that. Every ICH that walks through that door, you have to have the mentality is a potential surgical candidate. You have to instill the idea in everyone in that hospital that every ICH is a potential surgical patient, or it will become such an uncommon scenario that the intensity with which they're screening patients will falter. So I really try and make sure that I'm notified about every single ICH that walks through that door. And if they're not a surgical candidate, I will take my time to discuss why they're not a surgical candidate. The hematoma volume is too small. Their NIH is too low. They are moribund. They have too many comorbidities. They're on hemodialysis. They're a transplant patient, et cetera. But it's as important to identify and talk about who you don't operate on as who is a legitimate candidate for surgery. And I do think that the threshold for operating on patients will continue to decrease. The bar was set pretty high for Misty and Enrich. I think that certainly for some deep-seated hemorrhages, a lower initiating volume might be reasonable as opposed to low-bar hemorrhages where maybe a higher volume should be the trigger for an ICH evacuation. But in my mind, every ICH that walks through the door is a surgical candidate until I say otherwise. Chat did a nice job of talking about craniotomies versus endoscopic approaches versus the MISTY technique versus port-based approaches. I have come to the mindset that regardless of what my favorite evacuation approach is, I tailor it to what we have available at the individual site. You will do yourself harm by making demands about certain systems too early and too fast until you uptrain the people who procure your surgical equipment and especially your scrubs. So I would say use what you have when you arrive at the place. Use familiar vendors. You know, if you're a Myriad shop that uses Nico Myriad for tumors, well then I think BrainPath and the Nico Myriad might be an interesting place to start. If your hospital's been using Vicor ports for the last 20 years, maybe it's reasonable to do a couple port-based ICH evacuations with Vicor just to build trust and confidence, not only in your neurosurgical teammates, but also in your surgical scrub and your surgical team. I would focus on one technique. As Chris pointed out, I'm a strong believer in knowing how to do every surgical technique, but it comes at a significant cost to have all these different devices on your shelf. So start with one technique, become excellent at it, preferably a technique that might in some way already exist at your hospital. So when I started in Pittsburgh, we were enrolling in Enrich. It was very easy. Nico BrainPath was all I used. My favorite surgical approach, honestly, is probably what Chris described, the scuba technique. I love operating in a fluid medium. I love the way that warm irrigation washes away all blood products and promotes hemostasis. So I'm primarily for deep-seated hemorrhages, but even for some superficial ones, I love nothing more than a burr hole, a LOTA working channel endoscope, and I prefer, of all the things you can put down the 2.9 millimeter port, the 15 gauge Myriad. When I got to Cooper, we had just enrolled or in the mirror registry, so I had Aurora Surgiscope available. But then when I switched to Penn, we had nothing. So I used Vicor ports to evacuate hematomas until we had the Aurora Surgiscope available. And in the interim, I was using the endoscopic Myriad because at one hospital we happened to carry some Nico Myriads. I used what I had available. I made people feel comfortable. I didn't push too hard to initiate not only a new surgical approach, but a new patient population, et cetera. I bent a little bit to accommodate my circumstances. And I think that gave me a leg up than if I had just started demanding using things that people were unfamiliar with. When it comes to the clinical workflow, you can talk about ED to imaging, imaging to neurosurgeon evacuation, then neurosurgeon evacuation to OR mobilization. It's much simpler than that. Wherever I go, it's notify Brian Jankowitz about every ICH. Not because I'm the best, not because I'm overly important, just because I have a particular passion for evacuating ICH. And the fact of the matter is, most people don't, so they don't have a problem with you picking an orphan disease and running with it. So wherever I go, I make it very clear. Call me about every ICH evacuation, about every ICH that walks through that door, and I will take care of it. I will choose whether or not they need surgery. I'm happy to operate off hours, on call, off call, etc. If you call me, I will take it off your plate and take care of it. This, being notified about the patients themselves, this is different than just the images, which Viz and to some extent Rapid can do so well. This is about being called about the patients, particularly the ones that are likely going to the OR to get some clinical details. When I was at Pitt, it was the endovascular fellows. There's just a small, Navy SEAL team of people that I worked with every day. Those are whom I trusted to put me in contact or find out information about all the potential ICH evacuations. I went to Cooper and I didn't have fellows, so it was the research coordinator that I leaned on heavily to help me find the clinical scenarios. At Penn, it was the neurosurgery residents because we had radiology fellows, and I really wanted a surgically minded resident to inform me about any potential cases. And then finally at JFK, it's the stroke fellows because it's a small team that I work with daily that I trust to notify me about the clinical aspect of ICHs that walk through that door. But most importantly, it's got to be you. Wherever you go, you are not going to be able to depend on many others to carry the torch for ICH evacuation. If you don't have the mindset that it will likely rest on your shoulders completely, then you are bound to fail. And there are plenty of like-minded individuals out there that you can partner with, as a neurosurgeon or as an ICH evacuation specialist. But honestly, it's unlikely you're going to find somebody as excited as you are. So having the mentality that you're flying solo is a good first step. When it comes to imaging requirements, having access to CT or rapid turnaround and read availability, all this is washed away with Viz and to some extent rapid. All I need is to feed every non-con CT into some imaging app. I have not used AI docs or any other competitive services. I can't speak knowledgeably about them. I just believe quite strongly that today Viz probably does it the best. But I can't emphasize strong enough. If you're talking about bringing a vendor to your hospital or potentially switching from between Rapid and Viz, before it's installed, you want agreement that every non-con CT is going to be run through your app. It's the only way to keep track of all those ICH evacuations or all those ICH patients, effectively eliminating the necessity of a radiologist to either identify ICH or read those scans. You're just eliminating the middleman so that you can be in control of all CT scans that are done at your institution. If you're thinking about the infrastructure and resources you need to start an ICH program, Chat would talk about OR time, which is very important, ICU beds, which are there and usually at your beck and call, surgical supplies, ICH evacuation carts and kits pre-made, I think are also very important. But it's really, of all those things, it's figuring out how you're going to integrate a new type of surgery into your OR schedule. In the past, I think most neurosurgeons would wait on an ICH until it became an emergency. Either it came in as an emergency or they'd sit on it until a patient blew a pupil or herniated and then make it an emergency. And that's easy. It's easy to take 10 cases a year as a bang down the door emergency, disrupting the OR schedule and doing those cases because it's rare and you don't alienate many people. But if you plan to do this on a routine basis, you have got to weigh to fit into the OR schedule. You cannot make the OR schedule accommodate you. I was lucky in Pittsburgh and Cooper, which were trauma centers, because they always had a room available and ready to go 24/7 with in-house staffing for an emergency case. So an ICH evacuation did not disrupt the standard workflow of my cases, of my partner's cases, or of any other subspecialties. At Penn, this was a completely different scenario. If you brought in an emergency case, you were forced to bump someone from neurosurgery. And that is a very fast way to destroy your relationship with your partners. So very quickly, I learned I would add the case on and politely wait until the first neurosurgery room was finished for the day. And then I would politely take my seat or take my turn to operate at Penn. At JFK, there is simply a waiting list that you get added onto, and you could cajole them to maybe bump you up or down depending on the complexity or urgency of the case. But now when I have an ICH evacuation, I never disrupt the OR schedule. We have less ORs. It's a big deal when you bring in an emergency. So now I just add it on as an urgent case. It goes on a list next to appies and toe amputations, and I wait patiently until I can get that OR case. Extremely important to accommodate the OR. Be careful about making the OR accommodate you. The other thing that's important is, particularly if you try and get overly aggressive about bringing in a lot of different new technology, that new technology, particularly if you don't hit the ground running and you don't do many cases early on, some of those surgical supplies will expire. I just had a couple Aurora surgiscopes expire, embarrassingly enough, and so I'm going to have to re-up as we start the mirror registry. So you have to be the one that has tight oversight of your ICH surgical supplies. You should have a general idea of what's on the table, because it is highly likely you may be the only one using those supplies, or that you may have brought them in new. And if you bring in new supplies, particularly ones that are fairly expensive, because now these are all disposable and you pay a premium for them, when they expire, all eyes are going to be on you. So you want to be a good steward of bringing in new surgical supplies. Also, in an era where the turnover of OR employees, particularly the scrubs, is at an all-time high, I'm seeing a new surgical tech constantly. Knowing where the equipment is and all keeping it all kitted together in a corner under the heading of some ICH evacuation Carter kit is so essential. So you're not the one that has to run around and grab all these individual items scattered through your OR supplies. And then finally, you really want one person, one consistent person in the OR that can help you out. It's great for you to be that person, but when you're dealing with the patient and setting up the OR, you need someone else that can do that. And usually, I think most hospitals have a neuro coordinator or a neurospecialist. That's the best person to uptrain. It'd be nice to be that complex surgical scrub tech, but they're probably going to be in other more complex cranial surgeries, oncological, vascular surgeries. So it really should be someone, a coordinator who's bouncing from room to room and can help you set up rooms at least 7 to 5 Monday through Friday. Education and simulation, yes, you can develop clinical education pathways and educate the nurses and do simulations. You can do alert trainings in the ED and have drills, but what you really need to do is operate. You will find that if you don't operate on ICHs, it is likely that no one else will, or they'll do it in very select emergent circumstances. You're the steward, you're the flag bearer if you want to lead an ICH program. Therefore, you simply have to get in there and do it. And I've made the mistake at more than one institution where I tried to get all my ducks in a row before I ever started, and made it very difficult to finally initiate that first surgery, and it was such a slow ramp up. When I found that if I just chose my patients well, had backing from whoever owned that patient, whether it's neurology or critical care, then it was off to the races and it was a much faster ramp up. You simply have to get in there and operate. You will make mistakes, but you have to learn from them. But it has to start with getting in the OR, showing everyone that it can be done in a reasonable fashion without disrupting everyone else's life. You need to set some quality metrics for yourself. And I think that the two simplest are you need to ensure that you have some goal of what you're doing. If it's 99% GBM resection, for us, it's less than 15 millimeters at the end of every case. That will likely continue to decrease as we get better and better with these programs, but you have to have a metric that you strive for. You don't necessarily have to have intraoperative imaging, although that's wonderful. You don't necessarily have to bring the patient back to the OR if you don't achieve that post-op surgery end of hematoma volume. But you do need to critically analyze how well you're doing and figure out why you may not have achieved that volume. You need to review your complications, and I would consider a hematoma with more than 15 cc's left at the end a complication, and figure out why that's happening so you can get better. And that's why I love these mirror rounds, because it brings like-minded individuals to talk about it. And finally, and this is something that I find that's lost on a lot of early ICH evacuators, they focus so much on the cases that they do, on the operative volume, but it's actually much more important to think about and be aware of all those cases that maybe should have gone to surgery that are bypassing you, or that you're not aware of, or that your partners passed on, or that critical care made DNR DNI and you never had a chance to talk to the family. It is essential that you know the true N of ICHs that come through your hospital, which is why the Viz and Rapid are so important. So you have eyes on every single ICH, because it's the non-operative cases that we really want to know about to understand if you're missing cases. Financial considerations is something that has been hyped up quite a lot in papers because of reduced length of stay equals dramatic cost savings, less days on the ventilator, less days in the ICU. I will tell you that I've never won an argument with my hospital administrators or a critical care doctor or a neurologist when I started talking about financial considerations. I think it's much more effective to just operate and don't waste money. Don't order 4 of each individual device and let them expire. Don't get your name on the capital purchase list of people who are spending some of the most money in the hospital. Don't be greedy when it comes to wanting new devices or new technology. Use what you have on hand and be very considerate of the finances of the hospital, and don't be wasteful. I've always found these to be much more well received than when I try and stand up and declare that we're saving the hospital hundreds of thousands because the DRG is now going to pay for everything. It just falls flat on the people that I've talked to at 4 different institutions now. You have to understand your anticipated barriers, and perhaps this is where chat really nailed it. Unpredictable volume when it comes to, people want you to be able to anticipate having 2 to 4 ICH evacuations a month, but this is wildly erratic. You just can't anticipate the volume you're going to deal with. Staff coverage gaps or inexperience, resistance to new ideas, and getting patients into your hospital, all very realistic anticipated barriers that are highly dependent on where you're coming from. For me, it's always been just the resistance to new ideas, to the idea that ICH evacuation is a hot topic that has slowed me down. And it's manifested in different ways where I've been. In Pittsburgh, a pretty intense skull-based minded surgical approach institution, I got no respect. ICH evacuation was at the very bottom of the list with shunts with regards to how much props that I was given for doing these surgeries. I had to build a body of respect with good, consistent outcomes and using techniques that even some other complex skull-based surgeons were having trouble reproducing. I went to other institutions, and I'll try not to name names, and let's say there was a group of older surgeons that just had an antiquated perspective that all patients die after ICH evacuation and it doesn't help people. That was a tremendously difficult hurdle, and I have to say I don't think I ever really surmounted it. Changing the perspective of older surgeons can be incredibly difficult, so that's when you just have to operate and realize that you may be the lone man on the mountain. You may not get support from your neurosurgery brethren. Too many cooks in the kitchen is another major problem in the U.S. I'd love to hear from people on this talk, but I don't believe enriched move the needle one bit. I think the average ICH in the U.S. is still being cared for by general neurosurgeons who still have maybe a somewhat antiquated views of ICH evacuation, whether it's the technique or the abysmal outcomes. So I really want to streamline the care of ICH, and that's why it's just got to be you. Whoever you are in that audience that wants to build a program, it's all you that's got to build that program. You can't rely on anybody else. And then finally, in other institutions, it was simply staff experience with limited interest. The high turnover led to people that had very little understanding of how to use some of these devices and imaging and cameras. And so when you want to bring an ICH to the OR and you hear a perpetual groan throughout the OR staff, then you're doing something wrong. It's not their fault. You've got to get them interested in this technique. Maybe you bring it down to the IR suite like they do at Mount Sinai. I find that a very formidable challenge. It's great to think about, but often difficult to put into practice. But you just have to win over a certain subset of scrubs if you want to be successful. What's next when it comes to once you've established a program in a hospital, forget about all this. You just got to do it. You just got to do it and do it again and again to build everybody's confidence in you, to get comfortable with ICH evacuation. There is nothing more important than just being that go-to person to make it happen. In summary, it's all about making friends and avoiding making enemies. And these are very different things. You need to build the confidence of everyone around you because it is likely that ICH evacuation is not being done commonly or well, for that matter, at your institution. So you have to build support primarily from whoever controls the workflow of the ICH patients, but certainly from your OR staff and hopefully from your fellow neurosurgeons. You also have to do that without needling them. You cannot be bumping your fellow neurosurgeons every time an ICH evacuation comes in if you bring it to the OR, because no matter how well that patient does, they will not care. It is just, how are you ruining their second elective, fusion of the day? That's a big deal, not only for them, but for their patients and the hospital. So you've got to respect that. You've got to avoid making enemies. You're the interloper. You have to have that mindset every time. You have to make life easy for everyone else. You need a one-call number. That one-call number, Brian Jankowitz's cell phone number. That's what you need to disseminate. I put my cell phone number on my business cards. I give my business cards to everyone, and I tell everyone to call me directly if they have an ICH that comes into the hospital. And finally, join the Mirror Registry. What a wonderful way to validate that we are practicing science, that we are trying to learn from evacuating an ICH. We're trying to get better. We're trying to use new devices, and we're putting into a registry so that prospectively we can evaluate our successes, our failures, and get better. And with that, I'll leave you to it. I appreciate your time and happy to answer any questions if you have them.
Brian, what a great talk about the practical barriers to getting a program going. And you've done this now at 4 institutions, so
I've tried
no
it for
one's
you.
got more experience than you in trying to make it work and seeing all the different issues that come up.
I'm curious, Chris, is there anything that either rung wildly true for you or something that you absolutely disagree with that you've never encountered and it shocked you that might have been a barrier or a frustration?
I think the most important thing you said is that it's different every place. Like I'm trying to think of, where we were very fortunate in that somehow there was unified agreement that we were going to make this happen, across all the people involved in it, the multidisciplinary team. And so a lot of the roadblocks were sort of paved, from the beginning to get the program going. But I like what you said about just get started. Don't make sure you have everything perfect before starting, but also be selective and make sure you have consistent high quality to build confidence in the program.
Any questions from anybody else?
Hey, Brian, this is Karol Budachowski from Utah. We are just hoping to join the registry very soon, but I
Great.
wanted to ask you a question. We obviously have an established program, and ICHs have been evacuated, but I think they've been sort of treated very much in the old-fashioned way. When they're an emergency, they get surgical treatment. When they're not an emergency, they kind of get conservative management.
Yeah.
But overall, you may know this, Utah is a relatively healthy population, and I presume we don't have as many ICH evacuations or even patients with ICHs that come through the door as you guys do on the East Coast. What do you do to keep or start up this sort of program, and as you say, try to hit the ground running and just do the cases in a place that you don't see, just simply don't see that many, and you're not doing an ICH evacuation every week, even if you take all of them?
Got it. Carol, excellent question. I'll answer and then maybe Chris can take a stab. So a couple things. One, I would challenge you to find a way to guarantee you're capturing every ICH that comes through your hospital door. And I suspect that it's at least double of what you think it is, because there are so many ways for other services to siphon off the ICHs. So I mean, I'll just give you a couple examples. An older colleague of mine gets the call, looks at a scan, sees a 60 cc basal ganglia hemorrhage, tells the referring hospital they're going to die. Don't bother sending them. Let them pass at your hospital. You will likely never hear about that patient. Number two, if any ICHs are are triaged by general call neurosurgeons who have limited interest in operating on ICH, that's often a common way that you aren't aware of an ICH that comes in, where they might turf it to neurology right away or demand that the patient just come straight to neurology or a medicine service, and the neurosurgery service is not made aware. I'm not telling you that this is relevant in Utah, but these are the scenarios where there's a lot of ways for ICHs to be missed. So Carol, you have Viz, correct?
Correct. Yeah, we've got Viz.
Do you know if every non-con CT is going through Viz or just the identified stroke patients that are being manually triggered to go to Viz?
Yeah, that's a great question. I was just sort of trying to check this out as you were talking. So I definitely see non-con CT scans, but I don't think I see all of them. And
Okay.
so I was just trying to see that's like on my to-do list, is to speak with our PACs and Viz to see if we siphon all of them, or is it maybe special circumstances where we have, I don't know, trauma or brain attack, and then the CTA and the CT head and everything goes through it, but not necessarily all the plane scans that come through the door. Because
So
I certainly do not see all the plane scans, but I see plane scans.
got it. Yeah, those plane scans are probably just part of the CT, CTA, CTP, or CT, CTAs. One, figure that out. And if you're not getting all the non-con CTs, then I know you're missing plenty of cases. Two, if once you pick your device of choice, Aurora Surgiscope, there are other ways you can use that. At Penn, my partner and Duca Monclar used 4 times as many surgiscopes to do brain tumor surgery as I ever did with ICH evacuation. So if you do any other type of case, IVH washouts is a great utility for many of these devices to kind of cut your teeth in a low stakes environment. Try and find your way to use these devices in less high stakes environments in a more elective way. Those are 2 things I would say. I think Chris had to pop off.
No, I'm still here. I had to
Oh.
start migrating though, but I wanted to say, I think what you said about using Viz, and we had that same problem with not all non-cons going to Viz. So some were missed because for a while it would be, only patients done on a particular scanner or only patients who were ordered as a stroke code. But more recently, maybe like 1 to 2 years ago, we managed to get all of the CT scans screened by Viz, and that did make a big difference in the volume of ICHs we were catching through Viz. So that's really key. But I think the real essential piece is just trying to find a way to get the denominator of all the patients coming through to keep them from, finding their way, through the system without getting evaluated for an evacuation. And then another piece of that is making sure you've got some written down criteria from, a multidisciplinary team who is interested in triage of acute neurologic emergencies, maybe as a broad topic. And then you may have already worked out criteria for transfer and procedure for thrombectomy. And this should really just be a parallel process for patients who are coming in as a stroke code, getting evaluated. And then there are certain criteria for them to go to thrombectomy. There are also certain criteria for them to go to minimally invasive ICH evacuation. And I think that's been really helpful to, if the patient's within range there, then a consult call should be made to the designated person, whether neurosurgery or, the endovascular fellow or, the stroke fellow, whoever that triage point person is. I find using the parallel processes to be pretty helpful.
I'll just segue quickly. There was a question from Omaha, Nebraska about starting the program. I find if you try and ingratiate yourself with radiology, neurology, neurocritical care, it is overwhelming and so daunting you never get started. Every hospital has one whomever an ICH is admitted under, whoever the attending of note is, whether it's critical care, neurosurgery, or neurology, that's the person you start with in one-on-one meetings. I find that you can come up with a protocol of what patients meet criteria, but in the end, if you're just available and willing to operate, most places I've been are just so thankful you give these patients an option, a surgical option, that they quite honestly care less about the inclusion criteria or even how the patient does, more that you were just willing to give them a chance. And that's why just operating is so essential. I think we're going to have to end there and bounce over to a different meeting, but thank you so much for your time. And please feel free to call me or email me or text me if you have any further questions.
Thanks so much, Brian. I was going to say, nobody has written back that we have any cases to discuss, so I think we'll skip this IPI meeting this month and we'll just call it here.
Okay.
All right. Thanks everybody for coming.
Thank you all.
Thanks, Brian. I don't think it's fast or be fast.
Okay.
No, that's the acronym for people to recognize the signs of stroke at home, right? But we have a slightly different, I'm forgetting the name of it, having not used it, but there's one in New York that is used by EMS.
Oh, RACE, maybe?
Yeah, maybe RACE.
Yeah. In hospital, we use BFAST, and the addition of balance and eye abnormalities has dramatically increased the number of false positives. So that's
Okay. All right, maybe we'll get started.
Let's do it.
All right, everybody. Thank you for coming to Mirror